Okay, we're going to go ahead and get started. Thank you for coming to Pediatric Grand Rounds. I have a couple of announcements, and then I have the honor of introducing our speakers for today. It's not up on the screen anymore, but you'll see as you depart, there is a number to call and a code to enter in order to sign in for Pediatric Grand Rounds. That's how you receive CME credit, but no matter what, if you're a student, please sign in so we can keep our accreditation. That's wonderful. And then don't forget to fill out an evaluation form as you're leaving. So we are honored to have some guests from Vanderbilt here today, Dr. Lynette Gillis and Dr. Douglas Hanto. So Dr. Gillis is an assistant professor of pediatrics at Vanderbilt and is the medical director for pediatric hepatology and liver transplantation. She is board certified in pediatric gastroenterology. Dr. Hanto is a tenured professor at Vanderbilt. He is director of the Vanderbilt Transplant Center. He is chief of pediatric liver transplant. Both Dr. Hanto and Dr. Gillis have an extensive research program in transplantation, looking at both basic science clinical research as well as ethical considerations. Dr. Hanto and his colleagues were the first to describe the clinical characteristics of lymphoproliferative disease, or a complication of transplantation, and its association with Epstein-Barr virus. So we have some real expertise in the room today, and thank you all again for coming to Johnson City to present.
Hi, thank you. Thank you very much for the invitation. It's our pleasure to be here today. So just in terms of disclosures, my only disclosure to report is that I have a grant from Gilead Pharmaceuticals, as we're one of the 20 centers that does the DAA pediatric Hep C clinical trials in the U.S. So this is meant to be a very general lecture in terms of just providing a broad overview about pediatric liver transplantation. And in particular, we're going to focus on the elements of successful transplant programs, what is needed and required to have a successful transplant program, as well as indications for transplant. And I'll also talk a little bit about some of the specific indications and preoperative issues on waitlist management, including things like Hepatopulmonary Syndrome, Portopulmonary Syndrome, and cirrhotic cardiomyopathy. And then I'm going to turn it over to Dr. Hanto, who will continue to describe more of the surgical aspects, including donor options and selection, recipient procedure, as well as immunosuppression, post-op complications, and outcomes. And so from white paper from HRSA, Best Practice Models in 2006, really the elements that you need to have any type of successful transplant program are consolidated down into these two slides. So the key thing is that you have to have institutional vision and commitment, which is, fundamental requirement for any program. And you have to also answer a little bit of your question of why are we actually having a transplant program? Is there a need? Is there a resource need for a community? And so when we looked at transplantation in the state of Tennessee, when I arrived at Vanderbilt in 2004, there was actually not a single pediatric liver transplant center in the state. Likewise, the state of Kentucky doesn't have any pediatric liver transplantation, nor does the state of Mississippi. So there was a large geographic region of patients who were traveling even longer distances than what they're doing now. And it's important to say hospitals, can't just stick their toe into organ transplantation. It really is a very large institutional commitment and resources and support that's needed. You have to have a dedicated and experienced team of specialists who can work together both from a rounding standpoint as well as in the operating room. It has to be collegial and non-hierarchical to ultimately provide the best care. You have to provide very aggressive clinical care to these patients. both before and after transplantation, which I guess is probably the area that I specialize in more, certainly during the operation as well, but that pre-care and post-care is really critical to these patients. And then, you know, we get these patients from all over the state of Tennessee, from Kentucky, from Mississippi, and so ultimately these are children coming from our community that we want to return to our community. And so having patient and family-centered care is important so that their needs are being met and not the institutional needs. Trying to reduce their burdens. This is a very stressful as well as financially burdensome process that families have to go through when they're faced with organ transplantation for their child. Tremendous amount of stress for the family, increasing their educational opportunities, but also encompassing them into a lifelong healthcare model as well. Financial, as I mentioned, this is a huge financial burden, so having expertise in terms of the finances, who are going to communicate with this family, as well as payer relations, and then protocol-driven results. And so, you know, this is just a partial list of the various multidisciplinary people who function in part of the transplant center. So certainly myself and other liver folks within Vanderbilt, as well as Dr. Hanto and his colleagues, as well as not even transplant surgeons, but pediatric surgeons. But we have 2 coordinators, a social worker, child life team dedicated to transplant, ICU specialization. We have 3 pediatric liver transplant anesthesiology team. We have an immunocompromised infectious disease team, my GI colleagues, as well as genetics, cardiology, nephrology, radiology, as well as interventional radiology in particular is very important to transplant. Nutrition has a paramount importance. Ethics, administration, finance, as I mentioned, all have important roles in the evaluation and long-term management of these patients. And so what we're doing is we're providing medical care for infants, children, adolescents with liver disease. And these range, you know, by far most common cholestatic liver disease, as well as inborn errors in metabolism, which is really my particular focus of interest because I did a separate fellowship in biochemical genetics. Hepatitis and cirrhotic liver diseases, as well as acute liver failure and tumors of the liver. The transplant center also has to provide surgical care, which liver transplant is one of the surgical procedures, but there's other surgical procedures for these patients, including interventional radiologic procedures as well that have to be able to be provided, and train med students, residents, fellows, as well as collegial training on liver transplantation, and have a framework for clinical basic and translational research. So indications for pediatric liver transplant are different than in adults. So in children, you know, the vast majority of the pie, about a third, or sometimes even a little bit larger of the pie, is specifically related to biliary atresia. So unique that we have one particular disease that dominates the #1 cause for liver transplantation. And then the next area of the pie is really our metabolic and genetic. And so if you talk to adult people, you know, they're metabolic and genetic as things like Wilson's and hemochromatosis, but for us it's more inborn errors in metabolism that children are born with and that get screened for on their Tennessee newborn screens. And then the rest of the distribution actually looks a little bit more similar to adults. There's autoimmune diseases. There's 11% acute liver failure, which is actually very similar to the adult numbers. There's cirrhosis of various cirrhosis and hepatitic diseases of other etiologies. And I mentioned in terms of autoimmune, and then tumors occupy 9 to 10% of the pie chart there. And so by far the #1 thing that we deal with is cholestatic liver diseases, and obviously biliary atresia makes up the large share of that, but there's other ones as well, Alagille syndrome, primary sclerosing cholangitis, there's also something called neonatal sclerosing cholangitis, TPN-induced liver disease, and end-stage liver disease is fortunately very uncommon these days, and really only in the setting of combined with ultra-short gut. We have a classification of bile acid disorders called PFIC disorders where you don't transport bile acids into the canaliculus, or there's synthetic disorders of how you make bile acids from a cholesterol backbone. And then strictures and other obstructive type of etiologies in the biliary tree, and then the sort of the wastebasket term of neonatal hepatitis, which is really becoming smaller and smaller in that category of liver disease where we don't know what the etiology is as of yet. And then metabolic diseases, alpha-1 antitrypsin being the most common with a frequency of 1 in 2,000. Urea, and then cystic fibrosis, and then a variety of other ones, including Wilson's disease, urea cycle, glycogens, Kriegler-Najjar, something called neonatal hemochromatosis, which actually isn't as much of a metabolic disease as it is an autoimmune disease, and other types of inborn errors. And then acute liver failure, as I mentioned, is about 10% of the population. And then cirrhosis. And so probably the majority of children we see with end-stage cirrhosis are autoimmune or PSC-related liver disease. Hep B and Hep C are common in the pediatric population, but we don't see a lot of them have end-stage cirrhosis. And then some of these other specific genetic disorders that I mentioned, like the PFICs, can develop advanced cirrhosis as well. And so when their cirrhosis decompensates and their liver is not doing the basic functions anymore or has exceeded our medical management, that's the time that we consider transplantation. And then tumors like hepatoblastomas and hepatocellular carcinomas, and sort of a sundriest other category. And so biliary atresia is by far the number one cause of liver transplant, as I mentioned, and this is something that occurs in about 1 in 10,000 live births. A little bit more common in little girls than boys, more common in Asia, that's where the Kasai operation was developed, as well as more common in African Americans. And these children classically are found to have cholestasis as detected after 2 weeks of age. And so remember, any jaundiced baby, whether breastfeeding or not, after 2 weeks of age, if they're still jaundiced, the Academy of Pediatrics recommends that you obtain a fractionated bilirubin, so get a total and a direct. Etiology of biliary atresia, for all the research that we've done, still is poorly understood. There's clearly some genetic roles. There's inflammatory roles, as well as possible infectious etiologies, although to date, no specific infectious pathogen has ever been isolated from a biliary atresia liver. But there's mouse models that use viruses to simulate biliary atresia. And then in about 10% we'll have an embryonic form of biliary atresia where they have other congenital anomalies like malrotation and vascular changes, polysplenia, and cardiac malformations. And so ultimately the diagnosis is clinical suspicion, and I didn't put on here, but honestly, even before liver enzymes, is looking at the poop. And so you don't want to ask the parent. You ask the parents the poop, but most parents, and even parents who are even pediatricians, will tell you that the poop looks normal to them. So you really want to visually lay eyes on it. And there's several resources out there of stool cards you can actually pick out online that'll have colors of poops that you can show and have the parents point to the poop, or just have them bring the diaper in themselves, and so you can directly visualize that poop. But then we do liver enzymes. We do ultrasound to rule out any obstructive etiology like a colodocal cyst. We do a liver biopsy, and if that is consistent with biliary atresia, we go ahead and do surgery, which starts with an intraoperative cholangiogram. During intraoperative cholangiogram, they inject some dye into the gallbladder, and if it demonstrates that the biliary tree is not patent, the surgeon goes ahead and proceeds with a Kasai surgery. Typically, this is 8 to 10 weeks. So Kasai, why I say 8 to 10 weeks there is because Kasai, the data is very clear that surgery between 8 and 12 weeks in particular, but especially 8 to 10, has the greatest likelihood of success. After you get 12 weeks and beyond is when the Kasai surgery becomes less and less successful. And late presentations of biliary atresia that may already have decompensated cirrhosis may need to go straight on to liver transplantation. And so this is just a picture of the surgeon isolating the biliary tree, and here they're doing the intraoperative cholangiogram. And so if you look at outcomes, about 2/3 of children will have pigmentation in their stool. So again, when they come back in the clinic, these parents are well versed in bringing stools, or actually now there's, of course, as you would imagine with the Apple and the technology today, there's apps of poop colors that the parents can actually take pictures of the diaper, and it'll tell them if the poop is acholic or not. And so 2/3 will have pigmentation in their stools demonstrated by 2 weeks. So if you look at those who have that 2/3 early success, about half these patients will seem to continue to drain well. And I put in quotations cure because this is really not a cure. When you look at people even with their native livers at older than 18, we see that these patients still aren't doing great. They're still getting listed for transplant. They still have cirrhotic liver disease. But the other half will actually have earlier sequela of cirrhosis and complications of portal hypertension and will typically require transplant sometime in early childhood at the mean age of 5.5 years old. So then the ones who don't drain and continue to have acolic stools unfortunately do not do well. So that third of the Kasai patients will require liver transplant before 2 years of age typically. And so the data point that you'll hear is what your bilirubin is 3 months after your Kasai surgery. So total bilirubin less than 2, you're generally going to do on the better side. You may still have cirrhosis and complications of cirrhosis, but you're going to do at least early on okay. Those are greater than 6, those kids are all going to go to transplant. And so and then when you look at that 2 to 6 kind of range, really it tends to correlate best with growth. So the kids that are growing better tend to have a better outcome than the kids who are growing worse, not surprisingly in pediatrics. Switching over to another indication, hepatoblastoma. This is the most common liver malignancy that we see in children. There's about 200 cases reported per year in the United States. And key thing is that you have to have complete resection. Again, I'm not going into much detail in these individual diseases. Liver cancer, the other liver cancer that is thought of more in adults is actually quite rare in children, which is hepatocellular carcinoma. Certainly it's associated with Hep B and Hep C, but those are almost completely present in adults. There are isolated cases of that happening in children under the age of 18. But by far the majority of hepatocellular carcinomas that we see are either a specific idiopathic type called fibrolamellar that actually is in a non-cirrhotic background, or with specific types of metabolic diseases. Specifically, tyrosinemia is the one you think of, and even that ends up being a general pediatric boards question. And then that PFIC disorders that I mentioned also has a high rate of liver cancer. Interestingly, there's more data recently that there's more and more alpha-1 antitrypsin-related hepatocellular carcinoma, although again, that's out of the pediatric age range and more in young and older adults. And then any type of underlying chronic cirrhotic liver disease can have increased proclivity to developing hepatocarcinoma. So once you have cirrhosis, you have to be screening and thinking about these developments. Also, with the advent of the Fontan population, we're starting to see more cancers occur in children who are post-Fontan as well. So for hepatoblastoma, the gold standard is perioperative chemo. Typically, you do 2 to 4 cycles of cisplatin-based chemo, followed by complete resection. So we use transplant if the tumor remains unresectable after your cycles of chemo. And actually, transplant has an incredibly high success rate for unresectable hepatoblastoma, exceeding the 80% threshold. But low survival, 30%, 10-year survival for recurrent hepatoblastoma following chemotherapy and resection, where you do a rescue liver transplant. So you have to work with your oncologist. I didn't have them on that initial list of team. But you don't want to be doing this as rescue. You want to be kind of thinking about this early on in your management of the hepatoblastoma patients. And then those who have METs in their lungs at time of diagnosis have recurrence-free survival after liver transplant, similar to METs and if following chemotherapy. So pulmonary METs are no longer seen on CT, or residual pulmonary METs are completely resected with tumor-free margins. So in pediatrics, the definition of acute liver failure is a little bit different than in adults. So these patients have no underlying background liver disease and acute onset within 6 weeks of cholestatic hepatitis. They have coagulopathy that is not correctable with vitamin K therapy, and they may or may not have hepatic encephalopathy. And I won't go into details of hepatic encephalopathy other than to say it can be a tough diagnosis to make in children, especially our youngest of children. And this has a rapidly progressive course and has an 85% mortality without transplantation. So flipping over to contraindications, so certainly any extrahepatic unresectable malignancy, an underlying terminal non-liver disease, as well as uncontrolled sepsis or irreversible neurologic disease. And so how we allocate organs was changed back in the early 2000s. So a little over 10 years ago, we changed our organ allocation. So it used to be organ allocation favored being on the wait list. Now there's no prioritization for wait list. And the other thing that organ allocation changed was really prioritization to sicker patients getting transplanted. So we have a special category called Status 1A, which is specifically for acute liver failure, or if you have a transplant that has a primary non-function or develops a thrombosis in the hepatic artery within the first 7 days after transplant. There's a special criteria in pediatrics related to inborn errors of metabolism called Status 1B, and then Hepatoblastoma also has Status 1B exception scores. And for children under the age of 12, we use the PELD score. And so this is a very objective data based on specific labs. So you have your bilirubin, INR, albumin, age, prioritization being to those less than 1 year of age who have the highest mortality, and then growth failure. As opposed to those greater than 12 actually are the same as adults in terms of how they're allocated. So they have that 1A and 1B, which is quite similar, and then they have what's called the MELD score. So that does not have growth. So growth on this one and albumin is different on the MELD score. You have total bilirubin, INR, and then creatinine because of a higher incidence of kidney issues in adults on the liver transplant list. And the maximum score for a MELD is 40. And for a lot of our kids, you know, they may actually generate quite low scores and not be competitive, yet be very, very sick. So for instance, growth may not look that bad if you have a ton of ascites fluid, so that's why we have specific what's called regional review board exceptions. So you write a letter and explain why your patient needs a higher score. And so if you look at wait list and new listings in particular, so if you look at new listings in particular, you saw that it kind of dipped down back in the time when we went to the PELD system. And then generally it's actually overall been dipping down. And again, that's due to probably better advances that we have for some of our specific genetic diseases and sort of overall probably more aggressive care. And then this is just a time point of any given time of how many patients are on the transplant list. And so distribution of ages. So this graph on the left shows distribution of ages, which really shows probably our bulk of our patients are kind of in this 1 to 5 age range, and then the little bit older, but kind of pretty evenly distributed, and actually remaining pretty steady over many years of doing liver transplantation, and similar in terms of ethnic distributions, have overall stayed pretty steady. And then this is just looking at patients in terms of status post-listing. So lower axis showing how many months post-listing. So when you go out to 3 years, oops, sorry, I keep hitting that. So when you go out to 3 years, vast majority of patients have been transplanted. A small number have been removed from the waiting list over time. But some children do still die on the waiting list. And then what's kind of changed over time, and probably why we're actually doing better in terms of post-transplant survival, is living donor transplantation, especially when it comes to the smallest of children. This is similar in terms of mortality graph of showing that we actually are doing better in terms of overall mortality. So it sort of has trended down for all comers, and really that trend is in large part driven by the smallest age group. But these are the ones, unfortunately, that are the sickest and at highest risk for death while waiting for liver transplantation. Hepatopulmonary syndrome is another one that I was going to mention. So these are things that may ultimately lead you to listing a patient, or maybe something that occurs to a patient while they're actually on the list. So hepatopulmonary syndrome is where you get AV malformations in your lungs as stimulated by cirrhosis. And we don't know what the factor is that's coming from the portal vein pressure that's causing these AV malformations in the lungs, but you get selective VQ mismatch. And it can occur even in the setting of just simple portal vein thrombosis, so you actually don't need cirrhosis to have hepatopulmonary syndrome. But it is a primary indication for transplant. It actually has its own exception scores that the PELD and MELD system give to it. So clinically, the patient may come in with nonspecific findings. There may be some clubbing that you notice. You can sometimes see little telangiectasias. Sometimes they are bad enough to actually have some dyspnea or wheezing or even syncope. But the key thing is getting pulse oxes on all your cirrhotic patients every time that they come in. And for hepatopulmonary syndrome, they have something called orthodeoxia, so their SATs are actually worse when they're standing than when they're lying down, which is the reverse of how it should be for all of us. And so if they have SATs below 97%, then you really, and they have a known diagnosis of cirrhosis in particular, you want to go ahead and proceed with something called a bubble echo to document the presence of these AV malformations, or you can also do a tag scan. As opposed to something called portopulmonary hypertension, which is actually quite rare in pediatrics. This is more consistent with right heart failure. And this results from portosystemic shunting regardless of the severity of liver disease. Similar findings as noted, although I do feel like more of the portopulmonary patients will have more dyspnea earlier than the hepatopulmonary patients. And in your imaging, you may, in EKG, you may note a prominent pulmonary artery and right ventricular hypertrophy, although these also may be normal. Echo certainly will give you clues that there's increased right ventricular systolic pressure, but you have to ultimately do a right heart cath to document these. And severe severe portopulmonary hypertension is an absolute contraindication to liver transplant, while moderate portopulmonary can sometimes be treated with medications and still be successfully transplanted with improvement afterwards. So I'm going to turn it over to Dr. Hanto, who's going to take it from here in terms of talking about the donor.
There we go. Now, that better? Okay. I'm going to talk a little bit about the surgical aspects, both donor consideration and the recipient operation, and talk a little bit about outcomes. So I'll talk a little bit about donor selection, procurement, donor and recipient size, and living donor. The selection of donors has changed over time. We're using older donors and younger donors than we were when we first started doing transplants. So we use donors as old as 80. However, for kids, we generally try to restrict donors to less than 50 years of age, and in general, less than 35, although that's not a hard and fast rule. Most donors below the age of 35 are first offered to kids. That's one of the reasons why you saw the drop in mortality rate for pediatric transplant, is that over the years, priority has been given to kids because of the importance of good liver function for growth and development as well as brain development. The procurement of organs has really changed over time as we've introduced the use of UW solution many years ago that has extended the time that we can preserve organs. When I first started doing transplants, you had to have organs in within 6 hours. Now we can put livers in up to 12 to 18 hours and tolerate a longer cold ischemia time. Donor recipient size, we can use size-matched whole grafts, which by and large for older patients are better and have better outcomes. Actually, for the very small children, those that are in the 1 to 2 year age, it's just the opposite. Generally, split grafts do better in the younger kids, primarily related to size of the blood vessels. So using a 1-year-old donor for a 1-year-old recipient is probably not as good as using a split graft because of the small size of the 1-year-old vessels. I won't go too much into the details of reduced size grafts and living-related grafts in terms of how we size match. These are the annual report. These data are usually about 3 to 4 years out of sync. These are the most recent ones showing the number of deceased donors and living donors over the past decade since 1998 through 2011. And you can see that the number of transplants has remained somewhat consistent for both deceased donors as well as live donors for kids. Although you'll see here in the early days we were using many more live donors, but again, because of the primacy and the preference that kids get now for adult and pediatric deceased donors, there's less need for live donor transplants than there was in the early days of transplant. These are the transplant rates, and similar to the data that Dr. Gillis showed you, you can see here that the transplant rates for particularly the younger kids has gone up significantly as they've gotten additional priority, and we've used split liver grafts as well as living donors. So the transplant rates have gone up fairly remarkably, and that is translated into lower deaths on the waiting list. The other age groups have improved as we've gotten better and do more transplants, but not quite as dramatically as in the very young children. So I'll talk a little bit about liver transplant, the procedure itself. This is a preparation of the graft. This is on the back table. This is in cold ice UW solution. And you can see here, this is the artery that's being prepared. So this is done usually at the recipient institution once the liver has been taken out and brought back. This is the anatomy of the liver. This is probably more information than what you want to have, but let's see if I can go back. The liver, as you know, is divided into 8 segments: the caudate lobe, left lateral segment, segments 2 and 3, the medial segment of the left lobe, segments 4A and 4B, the right lobe, segments 5, 6, 7, and 8, with 5 being anterior, and then 6 and 7 posterior, and 8 anterior. And we can use segmental grafts. We can use the left lateral segment, which is the segment that's used for live donor liver transplants in children. We can use the entire left lobe using segments 2, 3, 4, and 1. We can do a right lobe graft. Not so commonly would we use a tri-segment graft, but usually either right lobe, left lobe, or left lateral segment are the most common grafts used in both pediatric and adult transplants. So this is an example of a left lobe graft. This is the split down the Cantilli's line right down through the gallbladder fossa. This is segment 5, 6, 7, and 8 for the right lobe. And we're taking segments 2 and 3, left lateral segment, and the medial segment 4A and 4B. So in this case, we get the entire bile duct, the hepatic artery, the portal vein, and the vena cava stays with the graft in this particular case. Now, in this particular example, the right lobe is discarded. In other instances, we can do this split in a way where the right lobe can actually be used in an adult recipient. But this is an example of a left lobe graft in a pediatric recipient. And these are the kinds of grafts that one can use. These are reduced or segmental grafts. Here's the left lateral segment with the left hepatic vein, the bile duct, left hepatic bile duct, the left portal vein, and the left hepatic artery. We can also, as I showed you in the last slide, the left lobe, segments 2, 3, and 4. We can use an in situ split. So these are splits typically done in the back table. We can also do the split in the donor and do this in the warm, where we split the segments 2 and 3 from the right lobe. This can then be used in an adult recipient. And then living donor grafts, a right lobe, left lobe, or the most common in pediatrics is a left lateral segment. So many different options depending on the size and the needs of the recipient as well as the donor characteristics. So this is an example of a reduced size graft. This is being split on the back table. This is being split right down the umbilical fissure into a left lateral segment graft, the left lateral segment here, and the right lobe and medial segment there. You can see the vessels are being tied off as the liver is being split. So again, this is the left lateral segment split where you use the left hepatic vein, left portal vein, and the hepatic artery, and then this is what is used in the adult. So living-related grafts are typically from a family member. They undergo an extensive donor evaluation. As I mentioned, it's generally a left lateral segment graft. As you know, live donor liver transplants in adults has come out of favor because of the high risk to the donor. This is one where the risk to the donor is relatively small, and left lateral segment grafts continue to be done when needed. In adults, it's usually a right lobe or a left lobe, but as I mentioned, additional morbidity and mortality that has reduced the number of these transplants being performed. This is an example of a CT-related angio. These are done to assess donor size, so we do volumetrics to make sure that the liver is adequate size for the recipient. And we also look at the biliary anatomy as well as the vasculature of the donor liver. This is an MRCP showing the right hepatic duct, left hepatic duct, and the important thing here that we want to know is that you can see that there's 2 ducts coming in here, so that if we were taking a left lobe graft, we would potentially end up with 2 ducts. So this is potentially a donor that would either not be used or would be at high risk for complications. We also do intraoperative cholangiograms that can show the biliary anatomy. Without going into a lot of detail, we use this quite a bit. This is an important one where you see the left hepatic duct here, and here's a right posterior duct that comes off the left hepatic duct. In this particular case, we would not proceed with a transplant because this duct would be transected and would end up requiring reconstruction in the donor. So this would be a contraindication for proceeding with live donation. This is what it looks like if you're either doing a live donor liver transplant or you're doing an in situ split in a deceased donor. This is the liver parenchyma being split. This is the left portal vein. This is the left hepatic artery. This is the middle hepatic vein, and this is the left hepatic vein up here. And these will be all divided then to provide the left lateral segment graft. So let me talk a little bit about the recipient procedure. This is a pediatric patient, obviously, with far advanced end-stage liver disease. This picture was taken almost 15 years ago. We don't see so many kids with quite this severe liver disease anymore in the United States. Most are transplanted before they get quite this ill, but not always. This is the recipient, or the cirrhotic liver, and this is the transplant after it's been successfully replaced. I want to point out a little bit about some of the recipient characteristics. First is to note the red arrow with the age. Notice that about 28 to 29% of children are less than 1 year of age. About 38% are between 1 and 5, and then another 32% are between the ages of 6 and 17. If you look down under transplant history, about 90% of these are being transplanted for the first time, but about 10% of the patients that we transplant and have transplanted are patients that have had failed transplant for a variety of reasons. Primary payer, about 43% are private, but we have a very high percentage of socioeconomically challenged families that make up our recipient pool and keep our social workers and transplant coordinators busy, making sure that they have adequate family support to support them through transplant. This, again, just to show you the time on the waiting list, you can see that because kids get priority, they're transplanted pretty quickly. You can see that about 17% within 30 days. And within the first 6 months, if you add these up, 16, 25, 35, 41, 51, almost 60% of patients are transplanted in the first 6 months. And by a year, most all of the patients have been successfully transplanted, again, because of the priority that they're given on the waiting list and also because of the availability of live donor liver transplants. You can see that about 23% are hospitalized in the ICU, but about 60% are transplanted as outpatients. Dr. Gillis mentioned the MELD-PELD system that came into play in around 2002, and you'll see here that with increasing severity, about 14.4% are status 1A or 1B. A lot of these are metabolic inborn errors of metabolism that get high priority after they've been on the waiting list for 30 days. And then, again, MELD-PELD of 14.7% or above 35, 13.3, 30 to 34, and a fairly small number at lower MELD-PELD scores. And as you can see here, about 64% have whole liver grafts, about 20% partial, and about 17% split grafts. So most kids still get whole organ grafts, and about 90% are deceased donor, only about 10% are live donor transplants. This shows the evolution of immunosuppression over time. In the early 2000s, cyclosporin was common, but cyclosporin has primarily been replaced by the use of tacrolimus. Azathioprine has similarly been replaced by the use of mycophenolate, and not much use of mTOR inhibitors, rapamycin. Steroids have been a big change. Steroid avoidance is the rule now in kids, where usually by 3 months they're off all steroids, with the exception of some children with autoimmune disease in which it seems to be better to leave them on steroids. However, there is beginning to be some data suggesting that kids that remain on a very small dose of steroids over the long term have less fibrosis. This is based on some long-term biopsy findings. Not much use of induction agents, very little use of T-cell depleting agents such as thymoglobulin or anti-IL-2 receptor antagonists. So the immunosuppression has evolved over time. Children are still at risk for rejection episodes. You can see here that by 6 months, about 10% have had a rejection episode, and by a year, 25%, and by 2 years, almost 40%. Most of this has to do with noncompliance. In adults, the incidence of rejection is only about 15 to 20%. That's how good immunosuppression has gotten. But this is particularly problematic in the teenage years, where compliance is a big part of the job of the pediatric hepatologist. These are incidents of one of the main complications of liver transplantation, and that is Epstein-Barr virus-related PTLDs. And you can see here that if the recipient is EBV negative, they have a much higher incidence of developing PTLD. Most grafts are EBV positive because they come from adults or other older children who've been exposed to EBV in the past. So we carefully monitor kids that are EBV negative at the time of transplant and get an EBV positive graft. So some of the operative complications that we worry about, primary non-function because of improvements in preservation is very low. Compartment syndromes where the graft is too big. Sometimes we only can close the skin and not the fascia. The grafts usually will shrink within a 1 to 2 week period, and by the time they go home, we're able to close the fascia. Hepatic artery thrombosis is more common in children than it is in adults. Portal vein thrombosis is also a little bit more common in children than it is in adults. Biliary complications likewise are more common in children and particularly more common in live donor transplants and split liver grafts relative to whole grafts. IVC and hepatic vein complications are very uncommon because of the size of the vessels. Just going to mention small for size syndrome, which we see if we use a graft that is too small for the child. Presents with jaundice, ascites, and failure to thrive. This is usually when there's a graft weight to donor weight that's less than 0.8%. Etiology is usually from hepatic congestion, that is just portal hyperperfusion, occasionally outflow obstruction, but usually it's inflow hyperperfusion. Treatment strategies can be to alter the portal flow by doing a portocable shunt, or in some cases by ligating the splenic artery to reduce portal flow through the spleen. Most important is donor selection. Just briefly mention the use of ultrasound after transplant. This is a post-transplant ultrasound that shows the main hepatic artery. You can see very brisk flow. This is the main portal vein. And this is another example of, this is hepatic vein flow here. This is an example of an ultrasound showing nice portal vein, but the absence of hepatic artery flow, and is very important in following children initially post-transplant for the diagnosis of hepatic artery thrombosis. And this is then oftentimes confirmed on CT angiography or on angiography, and you can see here's celiac axis with no further hepatic arterial flow. This is an example of hepatic artery stenosis, little kink right there. And if they thrombose, can go on to develop what we call ischemic cholangiopathy that resembles sclerosing cholangitis with areas of narrowing and areas of dilatation of the bile duct that can be shown on a percutaneous transhepatic cholangiogram. Here's the PTC catheter there injecting the bile duct. This is another example of cholangiopathy where a PTC catheter has been placed to stent the bile duct. Here's another example of a bile duct stricture. And let me just, and the placement of a stent across that stricture. We can develop cut surface collections, biomas along the cut surface of the liver, and these require then percutaneous drainage. This is a cholangiogram demonstrating extravasation and then subsequent placement of a percutaneous drain. Inferior vena caval stenosis is pretty uncommon. Can be difficult to manage because it's difficult to stent these because there's really no good landing zone because it's so close to the right atrium. So in this particular case, you can see the very marked narrowing here. This is the right atrium, and you can see that this is after dilatation of the vena cava. As I said, difficult to stent. In the interest of time, well, this is just another example of narrowing with the balloon and then actual placement of a vena cava stent with a landing zone just below the right atrium. Long-term complications include acute and chronic rejection, particularly related to non-compliance, bacterial, fungal, and viral infections. We don't have really time to talk about this. Renal insufficiency, hypertension, coronary artery disease in older patients, diabetes, and post-transplant lymphoproliferative diseases. Finally, I just will talk a little bit about survival. If you look at overall survival for all children, it's excellent. You can see here at 5 years, it's almost 85% are still alive at 5 years post-transplant. Pretty similar for all ages, but overall it's a little bit better for the older children than it is for the very youngest. The morbidity and mortality rate is certainly the highest amongst the less than 1 year of age, just because of the severity of their illness and the fact that they generally use reduced size grafts that do have greater morbidity and mortality related to infectious complications related to the cut surface of the liver primarily. These are incidents of graft failure over time. So if you look back in 1991, for example, graft failure probability was about 30% for those less than a year of age. You can see down in 2011, it's about 10%. So in all of these cases, risk of graft failure has markedly reduced as we've gotten better, and we continue to get better. And this is the same story for live donor transplants. Again, continued improvement over time in the risk of graft failure. And this just is a final slide, just talking a little bit about different types of graft. You can see here, whole organ, left lobe, and living donor all do a little bit better overall. Left lateral segment, not quite as well. So these are certainly our preferences for grafts. Left lateral segments, however, really become very necessary in those children less than a year of age. So I think, as Dr. Gillis mentioned, key to success for a transplant program that we hope to emulate is the people, teamwork, building consensus, mutual accountability, willingness to think outside the box and take chances, hard work, servant leadership, and willingness to solve even the most difficult problems and make some hard decisions. As Desmond Tutu said, if you want to go fast, go alone. If you want to go far, go together. So I think that's why I got here fast. Lynette and Michelle, because I could drive a little faster. Although I got a speeding ticket yesterday, so I had to be a little bit careful. All right, thank you very much. I'm sure Dr. Gillis and I would be happy to answer any questions, and thanks again for allowing us to be here to talk about this. Yes. I'll let Dr. Gillis talk about pre-transplant and post-transplant. In terms of actually arriving for the transplant, usually we have about 24 hours from the time that we're made aware of a donor until the transplant occurs. There's usually, lots of delays and things that happen. So there's usually plenty of time for kids to get there from pretty much anywhere in Tennessee, Mississippi, Arkansas, Kentucky, where we have patients.
So pre-transplant, we typically require the patients to be seen at least once a month while they're on the active list. And then they may be being seen locally in the community more frequently, even weekly, in terms of, weight checks and growth and things like that. Post-transplant, it really depends on how sick the child is at time of transplant. So a child who was in the ICU and really sick at time of transplant, may have a longer post-op time. Generally, hospitalization post-transplant is on average, for pediatrics, is on average 7 to 10 days. And then they go locally to Ronald McDonald House or an extended care facility. And then usually they're in town typically about 6 weeks, and then they come home. Any other questions? All right. Well, thanks again for the invitation.